Neurostimulation. This is the last topic that I'll be talking about in neuroscience research. This is my summary of the Sci 354 course from Macquarie University, talking about clinical neuroscience. To begin with, neurostimulation includes the use of direct, indirect current, as well as random noise. Basically, any form of radiation added, electromagnetic radiation added to the brain to cause something to happen. This can encompass deep brain stimulation, or DBS, which applies high-frequency current that is inserted deeply into the brain. It is used in Parkinson's disease to reduce dopamine in the basal ganglia and is used after a tolerance has been developed to medication. So individuals with Parkinson's, once they tolerate the medication that is used to treat their fidgetiness or spastic movements, then deep brain stimulation is used to encourage reduction, to reduce the amount of dopamine that is produced in the basal ganglia, because there's an overproduction of dopamine in that region. Subsequently, there is the Electro-convulsive Therapy, or ECT, which induces a seizure through electric shock, and this changes the brain by improving depression or anxiety. It has risks in removing deep brain tumors, since it may also remove other vital parts of the cortex. A probe is added while individuals do some activity, and it is used to tell what part of the brain is important for the said activity, notifying the surgeon not to cut through that area, as in this is in regards to the deep brain tumors. Moreover, there is Transcranial Direct current stimulation, or Tdcs, which is a non-invasive brain stimulation delivered via the scalp. It has the equivalent of 1 to 2 milliamps and relies on voltages that are naturally produced by the brain. One mustn't exceed 5 milliamps, since greater than 5 milliamps burns the skin. Aldini in 1801 used direct current stimulation to improve the mood of melancholy patients. Albert in 1960 used positive and negative stimulation to affect cortical excitability, and he affected cortical excitability differently. Transcranial direct current stimulation relies on anodes that deliver positive current into the cortical regions and increases positive charge, which makes the neurons more likely to reach action potential. A cathode is used to attract the negative charge current, inhibiting nearby cortical regions and thus increasing the aforementioned negative charge, thus decreasing its chance to reach action potential. A sham control is a control condition where current is briefly added but remains off for the experiment. The person doesn't know that they are not receiving the additional stimulation, and thus it could be used as an effective placebo. Advantages of transcranial direct current stimulation include cortical changes that continue to occur after the stimulation has ended, and this depends on stimulation length and intensity. TDCS is cheap, portable, relatively easy to use, and relatively safe, bidirectional, and Filmer et al. In 2019 found that the efficacy of TDCS correlated with current stimulation in the prefrontal areas relating to cortical morphology. Disadvantages of TDCS include the fact that it is bipolar, whereby pure anode/cathode stimulation is just not possible. It is poorly localized. It does not have a specific or focal area. It is more generalized in that regard. Different tissues have different resistibility. So, for example, the brain is a good insulator of current, and the cerebrospinal fluid is a good conductor, which thus this affects the effectiveness of TDCS. There are also sources of current that spread out and mix when using EEGs. Furthermore, TDCSs have no temporal resolution, so you can't exactly tell what's happening in real time with this device, and it can't elicit action potentials, since it is hard to know if it is doing something. This is from the aforementioned inability to tell if what you're doing is affecting the brain in real time. And single session TDCSs have no effect, no evidence of any effect, according to Horvath et al. High definition TDCSs use many electrodes, ranging from 8 to 20, and it models electrical current spreading throughout into the brain. This helps to control for any noise. So, for example, there might be one anode for 4 cathodes, and thus this can help measure the signal. Transcranial magnetic stimulation, TMS. It uses electromagnetic coils to stimulate the brain. 2 coils are used to create an interference pattern, which which stops the activation in certain areas and turn off parts of the brain. It measures the time course via electromyograms or EMGs, and there are electrical activity from calcium ions in muscles, which are recorded from moving the arm, for example, and the TMS records activity in the motor cortex. If there was a problem with myelin, the signal would take longer to travel from the motor cortex to the arm, and as a result, this can be used to find the homunculus. Coil localization. This focuses the interference on a certain spot and relies on EEG 10/20 system using anatomical landmark like Inian, Nasian, vertex EEG. The issue with this is that people have different brain shapes and you need a functional and structural scan for each individual before carrying out TMS. Control conditions. There is a large placebo effect since the machine is loud and it can stimulate the same areas but on different hemispheres or just stimulate different sites. Advantages of TMS include that it has good chronometry whereby you only need to wait 200 to 400 milliseconds to tell what's happening, to tell the immediate effect. The timing contributes to focal brain activity to behavior. It was also found that the role of visual cortex in tactile processing in blind subjects was important since blind participants read Braille and stimulating the occipital cortex could be interfered by the use of TMS. This creates a virtual lesion which can link brain activity with behavior. Hamilton et al. 2000 found that blind women lost the ability to read Braille after bilateral occipital lesions occurred, and thus the occipital or visual cortex is more important than the sensoromotor cortex in reading Braille. You can see here that there's action potential induction. As a result, we can see how certain parts of the brain are used for certain functions. Disadvantages of TMS include that it is dangerous for individuals with epilepsy since it could cause seizures or epilepsy. This is due to the fact that it causes action potentials, or rather it influences action potentials. There's a risk for individuals with head injury since those with metal in their head, such as implanted devices for severe headaches, brain-related conditions, or those who have heart condition, affected blood pressure, or who are pregnant or take medication, thus cannot use TMS. We must also consider the difference between online versus offline designs. You need to consider the time course of the study. Since if it is online, how is the stimuli to be ordered, and if offline, how long is the experiment and conditions distributed within the TMS time frame. One also needs to control for task specificity. So maybe a certain part of the brain is only responsible for a certain particular task and not any other task. So you have to account for that as well. And one needs to control for the placebo or behavioral arousal, since TMS is capable of producing large placebos, as we mentioned before. You have to control for sound and extra physiological effects like twitching, because twitching is annoying. And one also has to control for task specificity. Neurostimulation overall has advantages and disadvantages. The advantages include reversible lesions without plasticity change, changes to the brain that is instant and doesn't have compensatory effects, unlike drugs, because drugs have their compensatory effects. It is repeatable. Neurostimulation also has high spatial and temporal resolution. It can establish causal links between brain activation and behavior, and it can measure and change cortical plasticity. Disadvantages, however, include that only regions on the cortical surface can be stimulated. It can be unpleasant for subjects, causing twitching. There's a risk to subjects or patients. Stringent ethics are required, and it can't be used by some institutions. Localization is uncertain, and stimulation level is uncertain. One also needs to think about the purpose of stimulation, the type or where or control the condition, and the safety of the device. So in conclusion, we looked at neurostimulation. We looked at deep brain stimulation, electro-convulsive therapy, transcranial direct current stimulation, transcranial magnetic stimulation, neurostimulation in general. And that about concludes Neuroscience Sci 354. I hope you've learned something from this. Thanks for watching. Bye bye.